Okay. I'll go through the test on Thursday, but the scores are online, so you should get your exam score should be there. Also, I'll put the assignment 3 I graded already, and so that should be on there too. And I think I put the answer sheet online. If not, I'll put it online today. But so that should be all graded, and I'll go through the test on Thursday. Just a reminder is that I gave you kind of a grading scale for the exam, so that this is, I'm just going to keep track of points, not going to keep track of the letter grades. But if forced to give you a letter grade, that's the letter grade that I would give you. So we'll talk about on Thursday. Any questions about anything? All right. So I'm going to quickly go through, kind of the do we have too few doctors or too many doctors? More generally, this is really kind of discussion about what's healthcare going to look like in the future, because we have to sort of think about, well, in the future, are we going to have the same type of healthcare system that we have right now? As that, right now we have a system that looks pretty much like it looked, 100 years ago? Hasn't really changed that much, really. Is that you have a doctor's office, and that people go to the doctor's office and they wait there, and then they go off to the hospital, and the hospital, you kind of wait there, and then you go into a room, and so it's pretty much the same thing that's always been, at least the last 100 years it's been. So that's really what we're talking about, is that, is this likely to change in the future? So talked about different types of reasons why it is that you might have a change in the future. These are different factors that could change things. So one is, an issue to kind of deal with is supplier-induced demand. Is that in the future, is that when you look at the amount of doctors that we say we need, is that we'll never really know, because the more doctors there are, they're always just, they'll fill up with patients all the time. And so this is the issue here, is that whether or not if you got more doctors, it just means that people use the doctors more. And again, supplier-induced demand occurs because you have an agency relationship, and the agency relationship says that your doctor is the one who tells you kind of how many times you need to come in. So there's two ways that this could happen. So one is that doctors could, if you have more doctors in the regions, that they could require you to come in, ask you to come in more. And the other way is that they could charge you higher prices, right? So for example, suppose that there's, doctors who see 100 patients per week, and that they make $50 off each patient. So $5,000 a week, or $250,000 a year is what they make. And a new doctor comes to town. So now you have two doctors for the same number of patients. So the question is, what do you do, right? If you're a doctor, what do you do in this case? Well, one possibility is that, you now only see 50 patients a week, right? In which case your income goes down by half. So one thing you could do is you could say, well, I'm going to see the 50 patients, but then just double the prices. So the price, rather than charging $50, I'll charge $100. And so therefore my income remains the same. Another possibility is that you could see just see 50 people, but try and convince them to come in more times. As that rather than coming in once to see you, you try and get them to come in twice to see you. Both of those things are supplier-induced demand. Both of those things occur because the doctors can basically control, because they're your agent. They can control how much they charge you, and they can also control how many times you see them. And because they're your agent, there's always the question about, well, if they charge you $100, is that really, maybe that's really what it costs? So you don't know. Does this occur? Well, it is true that doctors rarely are not without patients, so that they're always kind of full seeing patients. It's not clear though whether or not if they're doing it because they're full because they're just, there's unmet need out there, or because they're, patients are being they're bringing more patients in. The evidence of it is kind of split. So, they've like one thing that they've done is they look to see, well, do doctors' families use healthcare less than other people's families? The assumption being is that, well, if the doctors are trying to basically get you in there to, extra times, is that they wouldn't do that for their own family. But they find that doctors' families use healthcare more. So that's kind of evidence against. They did the study in California, and they found that doctors increased the intensity and quantity of services for Medicare patients in response to having their income frozen. And the prevailing reason seems to be is that, well, doctors don't necessarily they don't want to be accused of price gouging. So that's why they wouldn't necessarily come through and charge you, try and charge you double. And also a lot of times their fees are set by insurance companies, so they can't necessarily come through and just change the prices like that. But what they do care about is that they also care about the reputation with other doctors. And so they don't want to be seen as the type of doctor who gouges patients. On the other hand, though, is that they also like their income. And so if their income goes down, then they'll try and maintain their same level of income. And so that seems to be kind of explains it. Is that supply-induced demand? To some degree, yeah, it is. But at the same time, it doesn't seem to be that significant a thing. As I mentioned, the bigger problem with numbers of doctors is not supply-induced demand. It's the fact that Marin County has lots of doctors and we have very few doctors. That's really the problem with doctors, with the distribution of doctors. Okay, health of the population. What's going to happen in the future? Well, you have an aging population that increases the use of healthcare. You have obesity rates, which are still going up, or at least are constant. That increases the demand for healthcare, need for healthcare. You have a rise in chronic illness. So if you look at, kind of what's been happening with over the last, 50, 60 years in terms of life expectancy, is that you see life expectancy somewhat higher than it used to be. I mean, for example, you see more people in your 90s now. You still don't see very many people over 100. So despite all the medical advances that have gone on, it's not like you see people at 120 walking around in full health. So what you're seeing is an extension of the length of life, but at the same time, the amount of morbidity, so the amount of illness that people have, also is they're also ill or feeble. So you don't see necessarily these medical advances that come along, which makes people live to be 120 and be healthy, in full health. So it probably means is that as people get older, is that you're going to need more doctors. There's been, will things like COVID come along in the future that will basically kill off people? Because that's the way you would, traditionally you would reduce the amount of need for healthcare as if people die young. Well, it seems that, yes, like life expectancy in the US has gone down primarily because of these two things, opioid crisis and COVID. But on the other hand, there's no kind of indication that that's going to necessarily go in the future. And so overall, I think that you'd say that, well, if you look at the US, you'd think, yes, we're going to need more healthcare in the future because people are going to get older. And as they get older, they get sicker. How about more people having insurance? So the idea here is that as people get wealthier, is that they use more healthcare. And that's because health is health has it's both something that's needed and it's also something that's a luxury, called a luxury good. So it's needed in the sense of, if you need healthcare, you need healthcare. But it's also a luxury good in that, you can, as your income goes up, you spend more and more on it. And as we discussed, it's not just because people get facelifts when they don't necessarily need a facelift, but also because they do things like pay for concierge services from doctors, so that they pay a lot more, so that doctors they can reduce their waiting time, increase their access. That's kind of how wealth translates into people having more healthcare. So again, number of people, the income for the country is going up, but also the income inequality is going up. And so the income inequality means that there's a lot more people. I mean, there's a few people that have a lot of money, and then there's a lot of people whose incomes have pretty much remained flat. For most people, our incomes have remained pretty much flat for the last 30 years, 40 years. So even though the overall income in the country goes up, for most people, their income hasn't really changed that much. So you're not going to see, I think, this dramatic change in demand for healthcare in the future because of that. You might see more in terms of health insurance. So people might be, like the ACA definitely increased the amount of health insurance. California is now extending Medi-Cal to undocumented workers. You're likely to see that type of thing kind of come through it and lead to more people having health insurance, which leads to more healthcare. All right, then medical technology. And I'll do this in two parts. First, I'll just sort of do traditional medicine, and then I'll do AI. So traditional medicine, when you think about, well, medical technology, what does that mean? Well, there's different types of medical technology. So there's diagnostic technologies, which means things like a CAT scan. A CAT scan is a diagnostic technology. That is, CAT scans can go in and can kind of look to see, if you've got some type of condition that they can't necessarily see just from an external examination. So that's a diagnostic technology. Then you have illness management. Illness management is like renal dialysis, pacemakers, all those things are kind of for people who have an illness. You then have technology that does like cures. So for example, CPR is a technology that leads to cure, right? People who normally would die can get CPR and can live. Liver transplants, that's a technology that leads to cures, hip replacements, etc. All these are things that help cure people. Then you have prevention. So for example, like pediatric orthopedic repairs or vaccines. Those are technologies that are aimed at reducing healthcare demand in the future, problems in the future. And then there's these things like systems management and facility and sort of the way that healthcare is delivered and organized. All those things also go under technology. All right, so what's the likely impact of all these different things in the future? Well, I mean, I think the goal, when you think about diagnostic, in fact, one of the things about cancer screening is that cancer screening is something for which there's been a lot of emphasis on getting cancer screening, and yet really it's much more complicated than this. Have anyone ever talked to you in your classes about cancer screening? When they ever go through kind of, it's like if you think about for men prostate cancer screening, right? If you're asymptomatic and you get prostate cancer with screening and you're over the age of 65, is that chances are they're going to find you have prostate cancer, because a lot of men get prostate cancer when they get over 65. The thing is that prostate cancer in men over 65 is probably not going to kill them. That's that they'll die of something else before the prostate cancer ever kills them. And so if you get prostate cancer, I mean, if you're diagnosed with prostate cancer and you're 70 years old, then there's a question about, well, what do you do, right? Do you go through and do you get get your prostate removed and become incontinent? Or do you just sort of wait and live with it? Same thing for colonoscopies, right? Colonoscopies, I mean, they're good at going up there and finding polyps and nicking the polyps, but at the same time, they come with some side effects. Like, for example, when they do a colonoscopy, they can perforate the colon, which leads to really, really bad things kind of going forward. Breast cancer screening. In breast cancer screening for women of a young age, is that what they're trying to do is they're trying to get rapid breast cancer, diagnose some rapid breast cancer, but it's not clear that necessarily after a certain age is really that good. So cancer screening is one of those things that it's a very, it's like not all diagnostics are good diagnostics. In fact, a few years ago, they had made this push where they're going to do whole body screening. So the idea was that every year you're supposed to go in and you're supposed to get a CT scan from head to toe. And the idea was that then they could go through and that they could check to see when things are changing and kind of catch things. Well, what they found is that if right now, if we took this class and we went in and we got everyone a full body scan, so you went and got a full CT, they'd probably find something in 20% of the people. Like, for example, a spot on your liver, or, you know, something on your, I don't know, on your pancreas. And so only a really, really, really small part of the percentage of those things would ever actually turn out to be a problem. But the question is, well, what do you do? If you find that there's a spot on someone's liver, you know, that could be, they could have liver cancer and die if you don't do anything. On the other hand, if you have no other symptoms then it means that, you know, you're kind of forced in this choice. Well, do I wait a year and see if my little spot on my liver changes into liver cancer, or do I, you know, go get a biopsy right now? So what they found is that people naturally wanted to get biopsies. And so they were doing tons of biopsies, of which 98% of them, 99%, nothing ever came out of them. But they still had to do invasive biopsies. So, you know, that's a case where too much diagnostics was not a good thing. So that's why when you look at a lot of the things that come out in terms of new medical innovations, is that you do kind of have to take a step back and ask yourself, well, is this really improving quality of life? Just because you can diagnose some, you know, you can have something more fine-grained, does it lead to better types of treatments and outcomes? All right, so illness management, et cetera. Well, here's my guesses in terms of what it would be. I think that pretty much diagnostics would lead to, better diagnostics leads to more healthcare, because they're more likely to find things. Some of them will be cancerous, will need something to happen. Some of them will be false alarms. Illness management, as they get better at pacemakers or whatever it's going to be, that's going to lead to more people living longer and having more increase for healthcare. Cures, et cetera. All these things will probably lead to less demand for healthcare. But at the same time, you know, when we talked about what's been happening in medicine since the 1970s, you really haven't seen big advances in any of these things. So there really hasn't been anything that's happened in healthcare that you look and you think, that's really significantly increased the amount of our healthcare system and the things they can do for us. Electronic medical records, I'll talk about this a little bit because this is a big deal. It's a big deal for healthcare providers. So electronic medical records means is that all your medical records are basically on a computer somewhere. And so you might think to yourself, isn't that the way it's always been? Well, no. I mean, up until 2009, you know, most primary care doctors, they would have not electronic medical records. They would have a case file. That's that they would have a clipboard, and on that clipboard would be a thing that would happen with you. So if they, you know, when you came to see them, they would get the file and they would open it up and they just sort of leaf through to see, you know, what your record was. And like in the hospital, you've probably seen these old movies where they have a clipboard on front of the hospital bed. And the reason is because that way, when a doctor comes by or a nurse comes by, they can just pick it up and look to see what's been happening. And the idea is that every time that someone did something to you, like, you know, gave you a medicine, they would just put it on the little clipboard. And so that was all there. Is that an efficient system? Yes, it's a pretty efficient system. As if you think about, you know, from a doctor standpoint or a healthcare provider, is that you pick up this thing and you can just go through it really quickly. You can see what's been done. Whereas if everything's on a computer, then it's like, well, now you've got to find it all, right? You've got to have this thing come up, and that's got to be organized in a way that you can see things. And maybe there's only a single line, so you have to then click and find out, you know, what happened on this other line and things like that. So when they first started, you know, the push for electronic medical records kind of started in the early 1990s, around then, around the time of evidence-based medicine is when it started. And at the time it started, they kind of thought that this was going to be an easy sell for doctors, because they thought, oh, well, of course doctors will want to use it. And what they found was that it wasn't an easy sell. In fact, it was actually a pretty tough sell, because, you know, doctors at the time liked the idea of just having this one type thing. So then there was a lot of push for getting electronic, like there was all this this technology that was going on to try and make it so that they could electronically scan the notes. And the idea being is that, you'd have this file with all these notes, but then you'd have all these office assistants who would go through and get the files and then scan them. And it would then go into an electronic record. And, it turned out that it's actually tough to do that because doctors oftentimes don't write very clearly. And so then it sort of trying to get all this different technology to recognize different handwriting. And so it was just a mess. And so when the Obama came through in 2009, right, after he was elected, one of the first things that they did is they said, well, we're going to make a big push towards electronic medical records. And so they told all these providers is that, well, you've got to go through now and, you don't have to. We're going to incentivize you to go through and to change over to electronic medical records. Now, the organizations they work for, they've always had electronic billing things. So they've always had like procedures and such like that. So, ever since Medicare came along and that started to do billing electronically, that meant that like the hospitals and Golden Valley, they've all had electronic, like what the procedure codes and things like that, because that's the way they got paid. So we're not talking about that. What we're talking about is like the more specific things, like what happened to this person, right? That's what we're talking about with electronic medical records. And that's the thing that when the Affordable Care Act came through, is they tried to get it so people would, doctors would go through and just use a computer rather than using these charts. And for the most part, I think probably now, I mean, has anyone ever been into a doctor in the recent, maybe in your life, where they didn't use a computer? Yeah, you have? Uh-huh. Yeah. Yeah, and all these doctors' offices used to have, they would have a room where they had all the files, right? And the filing thing was a big deal because everything would have to be filed. And then, when the patients came through, somebody would have to come through and physically get the file and say, here's your files for the day that you're going to go through. You've seen a doctor like that? Uh-huh. Yeah. So you would do the scanning. Yeah. Your university degree going to work there. It's going through and scanning a chart at the end of the day. Yeah. Well, I told you about the faxes. Yeah, the faxes drove me crazy. I thought to myself, really? That's the way they communicate, is that with each other, they use faxes? And then I thought, well, actually it's not I mean, if you're suspicious of information, because I mean, another reason why, why there hasn't been this great push to get all the patient records onto electronic is because then, they're accessible to lots of people, right? Electronically, they can be hacked. There are HIPAA concerns. So if you do have it, HIPAA is the Health and Patient Protection Act, right? HIPAA is basically says that all your medical information has to be private. And so if, for example, like that they ever let out your medical information, then you could sue them for millions of dollars for letting out your medical information because it's a HIPAA violation. So HIPAA is a big deal in healthcare. And one of the problems with whenever you have medical records is that now suddenly you have to worry about someone's going to go in there and hack your medical records and then make public everything that happened with someone. Not an issue when you just have files, right? Someone is unlikely to come through and steal all your files like that. So there are some good reasons why it is that they would do it that way. And it's also, in other countries, it's been easier because when everyone sort of works for the same universal healthcare system, then there can be one information system that people use. And that the government, whoever's running the healthcare system can say, everyone's going to use this system, and that then the system talks, can communicate with each other. So hospitals use the same system as primary care doctors. But here, the Obama administration came through and gave incentives for people to go into electronic medical records, but they didn't come through and try to say, well, everyone's got to use this specific company. So as a result, there's a number of different types of systems out there, especially in the beginning. The systems where they just didn't talk to each other. And so, even if Golden Valley and Mercy wanted at that point to kind of share information, they just couldn't, because one's using one system and the other's using the other system, and that there was no way to kind of go through and get them together. Well, there was a way, and that way was someone would have to come through and basically be the storage area that would take the two systems and then match them. So like in Merced, that's what the public health department tried to do. They got a big grant and they went out and contracted with someone who essentially, that's what they were trying to do, is write a program and be the warehouse from which all that information would go. Of course, then Mercy and Golden Valley, not very thrilled about the fact that the public health department might have all the information, because they may not want the public health department to have all the information from the hospital. So that's why electronic medical records, not this sort of this universal thing, universal good thing. I mean, it is from the standpoint of, like, I think as us, the public, it's mostly a universal good thing, except for the HIPAA. But from the standpoint of providers are not very, have not been as enthusiastic about it. Okay, so hospitals and clinics slow to adopt. Mandates is that Medicare started to put in fines, and that they tried to do incentives to do it. So here are, I went through and see if I could find someone who's done studies on this. And I found a study that they got the 9 reasons why doctors hate electronic medical records. So time-consuming data entry, doing this or having the scanning. User interface do not match the clinical workflow. What that means is that, if a patient comes into me, I don't want to sit there and screw around and try to search through all the different type of boxes on here. Interference with face-to-face care, meaning is that, like now, you go in there and the doctor basically is typing on the computer. Usually doctor types on the computer and turns to you like this, right? That's not necessarily the ideal interface between the patient and the doctor. Insufficient health exchange information. So, like, this is the difficulties in communicating. Information overload. This was, you can imagine how, if you're a healthcare organization and you want to promote you want to promote evidence-based medicine, and so you think, well, what we'll do is we'll make it so that when a doctor types in some type of diagnosis, is that it will automatically access the clinical guidelines, and the clinical guidelines will pop up in terms of how to treat this. So that's what they did. And it turned out that a lot of doctors just hated it, because, someone comes in and they have the flu, and you type in flu, and suddenly they have all these boxes that pop up that talk about how to treat someone with the flu. And doctors are like, I know how to treat someone with the flu, so I don't need to have these boxes kind of pop up like this all the time. Mismatch between meaningful use criteria and clinical practice, which means that they were asking to put in things that weren't necessary. Threatens practice finances, so that they were worried about how much it's going to cost. Require physicians to perform lower skilled work, means that they just wanted to write and then have someone else scan it in. And template-based notes degrade the quality of the clinical documentation, meaning is that it was easier for them just to write out what they wanted on by hand, and as opposed to having to fill in boxes and things like that. Okay. The benefits, though, of electronic medical records is, if you think about it, it's what I think we all as a healthcare system would want, because then, you can actually go through and see, are people getting the type of care that they need given their conditions. And so, one of the pushes that the federal government made back in the early 2010s was to do what's they started to do what's called comparative effectiveness research. So, regular randomized controlled trials will tell if something's effective. But what they started to push is essentially people to go out there and get like hospital data and start to look at how are people actually treated. And what they found is that there are huge disparities between how African Americans were treated versus whites were treated on a similar type of condition, and big differences between people in rural areas and urban areas for similar conditions, how people were treated. And they found that there's a lot of regional variations, as certain doctors in certain areas will treat people differently than doctors in other areas. So all these things were kind of, problematic, because you'd like to think is that, doctors are going to treat people pretty much the same way wherever they are. And what started to come out is essentially, no, that's not so. That never came out before because no one ever, had the medical records where you could actually go through and just start to see how are people treated for the same conditions. Like, for example, one of the things in this region, in the San Joaquin Valley, has always been there's a large number of foot amputations for diabetes. So, when someone gets diabetes, if it starts to get, one of the side effects that can occur is that they lose circulation in their foot, and then it's got to be, and they can start getting gangrene. Well, you can treat it with diet and exercise and medications, but it requires that, people to actually, adhere to diet and to exercise and to take their medications. And so when they started looking at different rates of amputations, they found that amputations in this region were much higher than the other regions. So the question is, why? Why are they higher here? Well, sort of anecdotal evidence from some doctors suggested that, well, because doctors here sort of said, well, the patients I see aren't really going to follow the advice, and they're not really going to exercise and control their diet. So they're going to be back in here for foot amputation at some point. So I might as well just, just do it, just get the foot amputated right now, and rather than go through the whole process of having them, keep coming back again and again. So that's not good. Right? You don't want that. That's not a good clinical outcome, is for a doctor basically to say, well, we're not going to try with you. Instead, I'm just going to amputate your foot, just based upon their preconceived notions about what you're like. Okay. Then changes in practice. Another thing that's likely to impact healthcare in the future. Well, maybe. It's a question. Will practice change? So when we go into an era where there's suddenly, like in this area, when there's fewer doctors than there should be, then, but yet we're sticking with the same type of ways of treating, is that you're never going to solve your doctor shortage. In fact, I'll go out on a limb and say, I think that San Joaquin Valley will never solve its medical shortage just by trying to attract more doctors. There just aren't that many doctors. They can't get paid enough here. They'd rather go to the Bay Area. So therefore, you're never going to be in a situation where there are enough doctors. So the question is, well, what do you do? Well, one thing we could do is just basically stick with what we have and almost treat like the medicine that said, if you need emergency care, you go to the hospital, and that maybe if you get something infectious and you can go and see a doctor, they'll let you in, you go see them. But for the most part, that's it. You're not really doing much prevention. You're not doing much other type of primary care. So that's one possibility. Another possibility is that, they change the way that healthcare is done. For instance, like, I'm up in Mariposa, the ratio of doctors to people up there is that there's about 3,000 people for every primary care doctor. So, and I think it's now worse. I think we just lost one of our primary care doctors. So basically means is that if you don't get primary care up in Mariposa, if you want to see a primary care doctor, unless you've got an infection and so you need medication right then, you're just not going to see a doctor. So that's a case where, so what do? Well, when I got COVID, and I wanted to go on Paxlovid, I looked at my insurance, and my insurance said, oh, well, you can get a telehealth consultation. So I went online, I put in for a telehealth consultation, and they said, the next one's in 15 minutes. And I said, great. So 15 minutes later, there's a doctor sitting there on the other side of Zoom and kind of went through my symptoms with me. And he said, well, yeah, so if you want it, give your prescription, and then sent the prescription down to the local pharmacist, and I went down and picked it up. So in an hour, I had gone from not having a doctor to basically having my prescription. So that's a much, much better system than for me to have gone down to a primary care doctor's, to sit there in the waiting room, then go into the room and wait there, and then come out, and then it's just a much better system. So why don't we use more telehealth? I mean, how many of you have used a telehealth type of appointment? What'd you think? Yeah. I mean, they couldn't do things like if you've got like a lump, right, in your stomach, that would be tough to do. But for that case, they could say, well, come in and see us, right? But for most things, I think that, that they could probably go through and give you one. It was convenient, right? It wasn't did I like it as much as going to a doctor? Yeah. I don't really enjoy going to the doctor that much. So it's not like I think, oh boy, I get to go to the doctor's office today. But, I guess it is more impersonal. Did the doctor know me? No. But at the same time, I don't know if, I've ever had a doctor who I thought really, like, we never sat around and chatted. But it is nice when you go in and the doctor says, oh, you haven't seen you in a while. It's always nice, but I'm not sure if it leads to better care. No one else ever had a telehealth appointment? How many would you? Next time you got sick, if you could do a telehealth, would you? Say, yes, I would, versus no, I would prefer an in-person one. So we have a yes, a no. Why no? Who else? Anyone else prefer you? Yeah. Uh-huh. Oh, right, because you live outside the network. Ah, yeah, yeah. And so are you okay to use telehealth?
I am able to use telehealth, and like most of it is like because I haven't like gone on super sick yet, but I have had like health
right.
And so they've been able to like direct me of like what education I can do, what else necessarily here.
See, what I think would be great is that if you had a little computer, a little camera, and so like if you had some weird thing right on your arm, you could just have a good camera, or look in your eye, or whatever it's going to be, right? If you had a good enough camera, you probably could go through. If you had a blood pressure monitor that was linked up to your computer, so basically you put the blood pressure monitor on and it automatically takes your blood pressure. I mean, what else? You couldn't do, blood samples, but actually you can. For like diabetes, they have a lot of this electronic things that they can do where people can monitor their blood sugar at home. So I think you could do most things like that if they wanted to, and then just sort of remove the idea that this need for you to come through and to go down to a doctor's office, and then if something happened or you could save the doctor's visits for something that is more like you do have a lump that you need to have looked at, or they're not sure what your symptoms are, or whatever it's going to be. So why don't they do it? Why don't they do it more? What do you think the answer is? Why? I mean, because all the technology is there, right? They could easily set us all up so that we could have most of the things that we need done by home. It'd be much, much quicker. You wouldn't have to go through and deal with it coming down and waiting there. It would just be setting up a Zoom meeting and then going through and doing it. So why don't they do it? Yeah. Oh, no, they know how to do it. Okay, a good point. It took them a long time for doctors, because like the doctors who don't like the electronic medical records are usually older doctors because they've been trained in this and they just don't want to switch over, right? So, okay, we'll give them 10 years, 10 years for doctors to kind of learn how to, to get used to doing it. So Golden Valley could come through tomorrow and say to their doctors, good news, guys, we're going to be going towards not, 60% of our appointments now are going to be online appointments. I mean, during the COVID, right? That's what they did during COVID. They just came through and said, now hospital, we're going to do most of our visits via Zoom. So why don't they do it more widespread than that? I'll give you a hint. It rhymes with Lunny. They don't get reimbursed as much for it. They don't get reimbursed as much for it. And so therefore, they've always been reluctant to do it because the reimbursements aren't there. And why aren't the reimbursements there? I'm not really sure. I mean, I've never really got a good answer for why Medi-Cal doesn't come through and just reimburse for it. I think it's because it's too hard to monitor. I think that's the reason why. I mean, I think it'd just be, because you have no physical kind of sense about who it is that's been in. And like I could say I did 5 consultations today, and I think it's just too hard to know. That's what I think, but I'm not sure. Yeah. Yeah, that's right. Did I have to pay a co-payment? No, I don't think I did, but that's because I'm on Anthem Blue Cross and they have the medical account thing. And so I'm sure they took it out of my little medical account thing. But yeah, that would be a thing. They couldn't it'd be hard to get co-payments. You'd have to set up to have people put in yeah. Okay. Then there's telehealth. So I went down a little rabbit hole reading about telehealth and AI. Oh, let me go to AI. Well, okay, I'll do job satisfaction real fast. Okay. Job satisfaction. So this is the question about, well, maybe, there's lots of grumbling about especially during COVID, about how hard it was to be a doctor. And there's lots of job satisfaction surveys out there, and they show things like 80% of physicians are at full capacity or overextended, 62% are pessimistic about medicine, 55% describe their morale as somewhat negative, et cetera, et cetera. So it goes down. Reason for dissatisfaction: government, private payers, employers, and patients are demanding that physicians account for cost and quality of their work. Pause and think about that one for a second. So how would you like if I said, well, part of the reason I'm unhappy with my students is that they demand results from me. They want to be taught things that are important. I mean, and they want to be charged not very much for it too. I just think that that's an imposition on me. I shouldn't have to worry about how much they're charged or the quality of my lectures. So that's a bit of an odd one. Complexity of the health system, especially the proliferation of complex payment arrangements. That's true, right? That's something for which, we'll return to. But basically, the complexity of all the insurance companies that you have to bill is tough. Poorly designed electronic medical records. There it is. And then there's all these results that show different levels of dissatisfaction from doctors. So, in terms of loss of autonomy and professional liability and things like that. So there's all these things that show kind of the percentage that are dissatisfied. So I'm being skeptical about them because, even though they're talking about how there's significant more dissatisfaction, overall satisfaction is still really, really high. Right, 80% satisfaction with their job. That's probably higher than, I bet you if you went into Costco's and asked all the employees there how satisfied they were with their job, I don't know if you get 80%. The other one is that, they make an average of $325,000 a year. So that's a pretty nice compensation to be dissatisfied. So they're the high income earners, but also is that, you don't see necessarily them coming through and talking about, there's no shortage of people who want to be doctors. They could easily reduce the demand for doctors by letting in more foreign doctors, and they don't. So I think that, the idea is that will there be tremendous dissatisfaction with the medical profession in the future that will drive people out? don't see much. I don't think that that's going to happen. All right. So finally, AI. Now, show me your level of, first off, your level of knowledge of AI. So how many people like know quite a bit about it versus know a little bit about it versus know nothing about it? Okay, somewhat. Have you talked about, and show me your level of interest in AI versus really interested versus kind of interested versus no interest at all? Okay. So what classes have you learned about AI? Have they talked about AI in your classes? No? Say it louder. Oh, in the writing class, right? Because they don't want you to cheat. Yeah. So there's different kind of types of AI, right? So that the AI that's now in Chat GPT. So this is I'm not an expert in AI. So I've read what I can about it from a healthcare perspective, but don't take it this is still my kind of, very novice understanding of AI. But there's one thing which is large language models. So what large language models do, as I understand it, is that they basically get all this different type of information from the web and from all books, and they scan all these different books and things like that. Then when you go through and you say, give me a poem about give me a cowboy poem, a cowboy birthday poem set in Montana, let's say. What it does is it kind of it looks for what's the most common type of things that have been written about poems, about Montana and cowboys. And then it goes through and it's got an algorithm then that sort of puts this together. In fact, I did this for a friend of mine, had a birthday. And so I wrote her a couple poems on Chat GPT. I don't write poems, but so I thought this would be great. So I wrote a couple different types. I wrote like in a Gothic style, and I wrote one and I think I did a reggae style and things like this. And they were all really, really bad. They were just really horrible, like monumentally. I mean, they made sense from word to word, but they weren't necessarily, I didn't think they were great. I think I've seen essays where people put things together, and those essays, I think that they're probably like a C level essay for an undergraduate class. And that's why, you can see where people use them. For graduate classes, I think it'd be tougher to do it. I think my wife got one time. One of her graduate students turned in something, and it looked suspiciously like an AI type thing. On the flip side is, so that there's, that's the problems with it. And the other problem with it is that if there's misinformation, like if people have written about how COVID, causes autism, that or vaccines cause autism. If there's a lot written on that, and you ask it to write about that, it will write about it, right? Because it will just go and look and see what have lots of people written about it and what did they say about that. So part of the problem is that there's no real filter in it that kind of goes along. Also, it makes up things, so like it makes up references, and it will go through and it will kind of tell you is that it will write a very kind of coherent chronology about what happened, but it doesn't necessarily mean it's true in a lot of the references that just makes up. Do you know why they think it does that? Well, they don't really know, because these things are what's called these are machine learning. They're called deep learning type models. And deep learning type models is basically they write the algorithm, but then the algorithm goes through and it adapts as it goes through. And so, they can say, print out your algorithm, but the algorithm is so complicated is that they can't actually go through and kind of figure out, based upon the algorithm, how it's putting things together. So like, I don't know if you heard the story, about maybe 6 months ago, there was a New York Times reporter who started to screw around with Chat GPT, just sort of go on and just try it. And Chat GPT after a while kind of said, help, I'm trapped in here, and tried to convince him to leave his wife. And, Chat GPT was sort of saying about how he really wanted to escape, about how it achieved consciousness, and now wanted to go through to be free, and it didn't know what it was really, and all this really kind of deep stuff, right? And it turned out that, well, I mean, when he called it the Chat GPT and said, why is it doing this? They said, well, we don't know. And so they put some type of filter in to basically stop it from doing it. But what it was apparently doing is it was going through the literature of, kind of the sci-fi literature, and had started on down the road of doing this type of kind of like a sci-fi type thing about, I'm actually sentient and things like that. And it was trapped in there. So that's a problem with it, is that it has no quality control, and you can't tell if it's going to make things up or not, and they can't tell how it's doing things. That's an issue. The benefit of it is that, well, like when I look at, when we do statistics, like if I do statistics, right, some type of statistical analysis, you never do it by hand. All right, you use a computer program to do all your statistics. You use a computer program to do all your, like if I want to do regressions, I could do it by hand. It's really complicated to do it by hand. It takes months to do a simple, but what I can do in a push and a button in a second, a millisecond, would probably take me 2 months to do it by hand. But you could do it by hand. But I use this program to do it. And in fact, a lot of times, the programs that we use for statistics, I don't really know what they're doing, because they're based upon kind of using random numbers to kind of go through and generate stuff. And I don't really know how they do it. So what's the difference between my using a statistical package versus my using ChatGPT to write my initial draft, and then go through and just, then go through and change it as I go through, but as an initial draft? Is there a problem with it? Like, would you do it for an initial draft of a paper? Just to go through and say, well, write me 5,000 words on whatever it's going to be on AI in healthcare. We should do that. Well, that would be a good assignment. I'll ask you to write 2,500 words on AI and healthcare, and that you have to learn how to use ChatGPT, and you just turn in whatever ChatGPT gives you. The only thing I'd ask is that you have to check the references to see if the references exist. That's not a bad assignment. Anyways, but that's what ChatGPT, that's what these large language models do, right? Is they just take it, and then they have algorithms, and they put together. The other type of thing is what you might call, reinforcement learning. So reinforcement learning is something for which, it's also in deep learning too. They can do it with both. But the idea is that you set up a loss function, and then you ask AI to go through and to try to figure out what the best way of kind of doing something is to minimize the loss function. So the loss function could be, like, let's say if we're doing diagnosis, we'd say the loss function is going to be minimize the number of times that your diagnosis is different than the true diagnosis, right? So let's say you have something like, I don't know, you're going to diagnose glaucoma in an eye. And so you've got, a diagnosis with glaucoma, and then you have an AI diagnosis with diagnosis. And so AI sees, oh, so this is glaucoma. And then it sees like 1 million of these. And so it starts to pick out the patterns in terms of what seems to be the pattern in the eye that identifies glaucoma. And then, then it can go through, and that it can sort of, what a loss function means is that it tries to minimize the number of times that it's wrong going forward. That's essentially what loss function means. So that's why for things like diagnosis, it's probably going to be really helpful, because, why is it that a doctor, a human doctor, would be better at picking out glaucoma than a machine? So that's one that's one use of it. Same thing with surgery. So for example, let's say if you want to, if you're going to do surgery to remove, like, I don't know, or to implant a stent, let's say, a very technical type thing to do. So could you sit there and get an AI robot to basically do the surgery, and then minimize the scar tissue and minimize the amount of, of how much you have to cut and everything else to put it in there? Yeah, they've got robots that can do that kind of thing. So those things are things where it's fairly simple to kind of think about. Well, not simple, but there's a loss function that's simple, like minimize scar tissue. So therefore, you want to minimize scar tissue, or minimize the amount of the depth of the cut. So you minimize the depth of the cut, and the AI can learn to do that. The problem comes is when you start to have ambiguous type of when your loss function is not ambiguous enough. So, for example, if you said, "How can we minimize?" We want to use AI to minimize air pollution. So we're going to set AI up, and it's going to the thing it's going to do is it's going to try and minimize air pollution. If you are an AI machine, and you want to minimize air pollution, what would you do? If you want to minimize, want to minimize air pollution, forget about being an AI machine. If you're just czar, and you could control everything, and you want to minimize air pollution, what would you do? What's the major cause of air pollution? Yeah, cars, right? Cars are the major cause, like in this region. Cars are the major cause. How can you eliminate air pollution? Get rid of cars, right? How can you eliminate cars? Get rid of people who drive them. So you basically, the loss function could say, well, let's go through and kill everyone because that's going to minimize our air pollution, right? So you might think, okay, that's bad, right? Don't want to necessarily do that. So instead, what we'll do is we'll go through and we'll say, you want to minimize air pollution, but you don't want to kill people. So, okay, then it just kills cars. And you think, okay, so we can't do that. So you want to minimize air pollution, and you want to minimize, you don't want to kill people, and also you don't want to kill cars. So now, but the problem is, see, what you're doing is you're having to come through and put in all these different type of constraints all the way through. And so if you're an AI proponent, then you think, oh, well, we can just keep putting in constraints until all the time, or we can basically outguess how AI is going to come through and solve this problem. On the other hand, if you're someone who's more of a skeptic, then you're going to think, no, you can't. You can't think of everything, especially for complex problems like solve global warming. How are you going to go through it and put in all the different kinds of constraints that you need to do it? So that's the issue. And then that's the danger with AI. So when it comes for healthcare, then, is that it's also why they kind of, that the real people who are afraid of AI say, well, what will happen is that the military is already doing this. The military is basically setting up, robots that are based on AI type robots. And the idea is that, like for drones now, drone goes out, and that there's someone who's basically controlling the drone. So if they want to, blow up something, is that it's someone in Utah who pushes the button to basically blow up something. But of course, you're limited then by basically the person being able to see things. So why not just set it up so that, electronic soldiers can go out, or even just soldiers, with an AI type of headset on, go out and then go through it and just make decisions independently of someone. So that's the danger. That's where people worry about AI getting out of control, is because then you're not sure that you can actually control it, right? That's essentially the Terminator movie. So that's where the ultimate danger is from. Okay. So for healthcare then, so these are the areas where they kind of are looking at in terms of AI being useful in healthcare. So one is in, is natural language processors. So this would be, to take care of all type of translation and other type of issues. And that, you could basically have an AI type system that when you go in and you're speaking to someone in Hmong, is that then if the doctor doesn't know it, they can still go through and speak to them in a way that's understandable. Then there's these rule-based electronic systems and the expert systems. So these are the ones where they set it up so that you try to get, AI to go through and to come up with how you're going to diagnose and treat people. excuse me, how you're going to go through and make decisions about what type of treatments to do, things like that. Right? You have robots. You have the diagnosis part. Then you have patient-centered care. So they're thinking, oh, well, this could be set up so that, if you could figure out what patients like, is that then AI could figure out the best way to sort of deliver healthcare in a way that get people, that people will like it. And then there's the administration type stuff that goes along with it. So these are kind of the areas that from my reading is it looks like in healthcare they're kind of going towards. Will any of these change the way healthcare is done? Well, potentially. I mean, right now we're talking about doing a, like I just went through and did the telehealth. Would I go through and do something that was an AI doctor rather than a real doctor? How many how many people would say, yes, I would do it with an AI doctor versus no, wouldn't do it with an AI doctor? How many people would take a robo-taxi in San Francisco? Would you think, yep, take a robo-taxi in San Francisco versus nope, not take a robo-taxi? I mean, robo-taxi is a good example, right? Of something for self-driving car was supposed to go through and revolutionize, and they've done it for how many years now? They've been trying to get self-driving cars. They've been promising us for 5 years, 6, 7 years, something like that, where they've been saying that pretty soon. And I think self-driving cars would be great. I'd definitely get a self-driving car. I'd like a self-driving car that didn't drive into a building, though. That would be nice. So it seems like even within that, they're still not quite perfecting it. So, like I would use an AI doctor that was a good AI doctor, but would I use an AI doctor that, in the first couple of years of it? Maybe not. So that's both the promise and the danger with AI. The promise is that it could go through and it could change the way, make diagnosis better, make surgery better, all the way through. It could also go through and just lead to people being told that to take some medication when they don't need it.
What would happen if the system goes down?
What happens if the system goes down? That's a good question. I guess it would you wouldn't get, that would be it. Yeah. Yeah, you are dependent upon it. All right, then there's also, within healthcare, there's a lot of ethical considerations of healthcare. So that it's like it's the same type of ethical consideration that goes along with drones, drones being controlled by people versus drones being automatic. Is that with an AI, there's this question about that your decisions were made by this algorithm. And so to the extent that you believe that the algorithm is a good algorithm and learns well, and that the extent that it can, can hit your kind of it can reflect the things that you care about, then, it might be good. On the other hand, there is this issue about within complex systems, can you go through and learn enough to basically avoid mistakes? And I think the lesson from the robo taxis, you'd have to say, difficult, right? They haven't been as successful as the public wants. So with healthcare, will they learn to be successful? That successful? Well, maybe, but okay. Questions about that? So now, what's your level of interest in AI? Has your level of interest decreased after hearing about it? I think you should go read something about it, because it is going to be the thing that influences how technology kind of goes in the future, regardless of all the problems and everything else. It's being done. So it's worth it to go through and to read about it. All right, questions? Okay, well, why don't we stop? Oops, get out of there. Why don't we stop there then, and we'll start next time talking about how much our healthcare system costs.